questions they can ask. So today we have Dr. Mark Greenberg, Dr. Ronnie Barr, and Dr. Sheila Weitzman, and I'm not even going to try to do introductions past that because they're going to do much better jobs themselves. But maybe we'll start with most of the people in this room know you, but a lot of people don't because we have all of our fellows here as well. I was joking with Mark prior that one of the changes since Mark was here is that we now make all of our fellows dress in uniform, clearly. But so, Mark, do you want to go first and tell us a little bit about how you got introduced to pediatric oncology in Ontario and ended up here?
Yeah, thanks very much, Sumit. Thanks for having us. I'd just like to start with a little anecdote. For reasons that are unclear to me, when I left South Africa, my mother insisted that she should send me my medical school notes. And I looked back on my medical school notes, and in 1964, the hematology lecture said, lymphocytes are small round cells in the blood whose function is not known. And that's how far back some of us go. So when I finished my training, and I suspect it's true for Ronnie as well, we were really at the beginning of specialty training. And in my world, everybody wanted trainees, and they offered all kinds of inducements. And I was offered a McLaughlin Fellowship to study infectious disease and come back to a staff position. And I said, sure, that'd be lovely. And then I did my last rotation as a senior resident, a chief resident, which was on hematology oncology. And I bailed on infectious disease. And I bailed because what I really wanted out of my career was a longitudinal exposure to children and families over a long period of time. I wanted to understand physiology. I wanted to understand behavioral, what happens to people who have children with cancer. And I wanted to make a difference. I wanted to change things. And that's why I went into oncology. When I started, and I'll take 2 minutes more, everybody did everything. We did hematology, we did oncology. We looked after kids in the ICU bleeding like crazy. We looked after kids primarily with leukemia. The solid tumors in those days were housed at the Princess Margaret Hospital away away. And so we didn't see any of those. Brain tumors were not things that we got to see. They were looked after by neurosurgeons, and certainly there was no oncology. It was, so when I began my staff position, it was shortly after the publication of the first St. Jude's trial in leukemia, and we tried to emulate it. CCG and POG were just beginning, and we alternated actually between CCG and POG. And slowly over time evolved into becoming full members. In, I guess, 1988, we differentiated into people who did pretty well exclusively oncology and pretty well exclusively hematology. And the field blew up from there. So that's how I got into it.
Just for putting you on the spot, but what year was it when you started your staff position?
When was it? 1973.
Thank you. Ronnie, you want to go next? We can switch too.
Well, let me start with a confession. Can you all hear me? Good. I'm not a pediatrician. So I start from a very different base, and the trajectory that I've taken to this point is somewhat different from that of Mark and Sheila. I grew up in Scotland, went to the University of Glasgow, trained in internal medicine and hematology. mentor at the time, remained a mentor for many years, said, you know, Ronnie, you should go to Africa. What is the message? But it turned out that when Kenya had become independent in 1963, one of the arrangements that was being made as it transitioned from being a British colony to being an independent country was that there would be help given to establish the first medical school in the country at the University of Nairobi. And my mentor had been the first person to go out under that scheme. He was there for 6 months. He obviously so enjoyed it and saw so much opportunity that that was the real reason why I was getting that go to Africa. Well, a background of internal medicine and hematology, I found myself having to deal with many young people who had diseases that I had read about, never seen. Imagine the plethora. Tropical disease, challenging in itself. And it was compounded by the fact that there were no pediatricians who had been trained in hematology or oncology. So it fell to this one and another person who happened to be there, Yale University, to provide some measure of service for the children with cancer and blood disease. So that was my introduction to pediatric oncology, if you like, without any formal training. Then became great friends with someone you may all heard about, John Ziegler. John was the man who'd been sent out from the National Cancer Institute to establish the Lymphoma Treatment Center in Uganda. Met him at a meeting in Kampala. We became great buddies. And when he went back to the United States, he said, why don't you come to the NCI as a visiting scientist? So I did. After a brief return to Scotland. Spent 2 years at the NIH, entirely in a laboratory. Great fun. Actually quite productive, but hardly pediatric oncology. And then I returned to Scotland, and one Sunday, it was in January 1977, phone rang. The voice said, this is Alvin Zapursky from Hamilton. I've got a job for you. Zapursky, you have to understand, I'm not a pediatrician. This day I remember exactly what the response was. No problem, you'll pick it up. Well, I've spent the last 40 odd years picking it up. He said that I never really was comfortable when asked to go and see 150 grammar in the neonatal ICU. I thought, I can't possibly touch that. It'll break. So I've come at this from a rather different background. I think it's fair to say that enjoying close relationships with people like Mark and Sheila, others, and picking it up on the way arrived at a point where I can reasonably say I had a career in pediatric oncology.
Thank you, Ronnie. Just for the fellows, I would suggest not waiting for a random phone call to offer you a job as your strategy, and maybe not saying I'll pick it up as an interview question. Sheila.
Okay. My story is a little different. I can't say I was driven by any great impulses or anything else. I actually fell into it by chance. And the message for you guys is you have to be in the right place at the right time. And so so luck has a role to play in this. So what happened to me was I trained obviously as well in the same medical school as Mark, and finished undergrad training there. I was going to be an internist, an internal medicine specialist, but we had to do 2 years before we could do a residency in South Africa. And in the second year, I decided I'll do pediatrics just to pass the time. Well, I loved it, and that was completely changed my whole life, my lifestyle. So I then applied for and got a pediatric residency Africa and finished pediatrics there, and then went on staff in the hospital in Johannesburg, but as a neonatologist. I was a newborn specialist. However, after a number of months, the hematologist left to go back to the and there's nobody to do hematology oncology. So the most junior person on staff gets handed with whatsoever to run the whole program. And so everything done by the book, high dose methotrexate by the book. It seemed to go okay. There were glitches along the way, I can tell you there were, but it seemed to go okay. But then when, as a family, we decided to move to Canada, had 2 young boys, 2 at that stage, and felt, rightly or wrongly, that there would have to be a revolution before it changed there. So we decided to come to Canada, and I decided hematology aside, I liked hematology oncology, and that's what I was. So I applied for actually 2 at Mac and one at Toronto. I got the job in Toronto and started as a trainee in Toronto in long ago, 1970. At a time where there were running, trainees. But even then, there was some, there was some, some control of what we could do at night. So we could do 2 nights out of 3, 2 of us. So we did 1 night in 3 for 3, covering the service as a trainee at SickKids, as a fellow in the hematology oncology. But I would have to say, it was very difficult, and especially with 2 boys, but I enjoyed it absolutely. I really did. I remember this. I had a great time and really enjoyed it. And then when I finished the exams and everything, having had to do the LMCs as well as going back to learn gynae and surgery and plastics and whatever else I had to learn. And then repeat a fellowship in Canada. Luckily, I didn't have to do pediatric time. I had to do the pediatrics fellowship, which I did. And then luckily a job comes up just as I finish off training, and that's very different. That's what I mean, in the right place at the right time, because the job came up just as and we didn't have. I came 1981, actually the exact same day that Dr. Alversky, that Ronnie's already spoken about, the most wonderful, took over hematology and oncology at the head of hemo. And so that was, I just by chance fell into things. And what I would say to you is a question I get asked a lot by particularly is how to enjoy it, and was it difficult? And the honest, I mean, I won't go into detail right now, but I absolutely have never, ever, have to say, it is a fantastic, never got up on it thinking, oh God, I have. And so it's really worthwhile, pursuing. I think it's an amazing career. It's not that it's not stressful. I don't, of course it is, but it is, it's been a great, great career. Just got to be lucky and in the right to do it.
I have no idea how to turn on my microphone.
Just Paul, one thing, just if we could remind everyone, just so the folks online can hear well, speaking directly into the mic.
So I was chatting with Sheila and Ronnie before and saying sometimes when I talk about survivorship, I show this slide from the Childhood Cancer Research Fund, which has 4 crayons on the one side and 95 on the other. And under one, it says leukemia survival in the 1950s, and the other is leukemia survival in the 2020s. So a lot has changed between when you began and where we are now. So I was hoping you could each speak a little bit about what you've seen as the major changes over the years.
Again, I want to take you back. When I started, ALL was ALL. There was no way to differentiate T or B. We knew that some kids did less well. But one of the fellows in my years as a fellow was studying how to figure out what's a T cell and what's a B cell. You will recall that T cells were identified in 1971. It was a revolution to understand and to begin to tailor therapy. And I think that's one of the hugest, biggest changes, to be able to identify who's at high risk and who's not. I think the other huge change is the orientation. In our early years, the challenge was cure. And when we achieved 5-year survival, we said, cheers, have a nice life, and all will be well, and you're fixed, and don't worry about it. And as Paul points out, that didn't work out so well. And we really had to rethink, as we became more and more successful in cure, what we had in the process done to kids. So survivorship has become really a key component of the practice of oncology. The one other thing I want to just highlight, if I may, is in the early days, the behavioral sciences and the behavioral professionals really weren't part of the team. And that really, really had to change. I was just telling Mary, I was sitting on a bench, having just come off the subway, waiting for my wife to fetch me. And I sat down, there was a woman next to me reading a paper on medulloblastoma and its long-term outcomes. And I turned to her and said, who are you? I know everybody in the city who's interested in medulloblastoma. Her name was Brenda Spiegler, and I hired her on the spot, and she became the head of psychology here. So, right time, right place.
Let me start with an anecdote that picks up a little bit on Paul and Mark were talking about. And Mark will remember this event quite clearly. He and I at one point co-chaired an entity called the Canadian Children's Cancer Surveillance and Control Program. Happily, we've got the title shortened now to CIPC. This is an entity that really resided within the Public Health Agency of Canada, but much of the work was determined by those of us who were engaged, as Mark and I were, trying to push the envelope for the country at large. The anecdote relates to a meeting we had with David Dodge. At that time, was the Deputy Minister of Health. Went on to become Governor of the Bank of Canada. And we were given an audience with Mr. Dodge about 45 minutes, as I recall. And it was so long ago, Mark, you'll remember, that we took with us a bunch of overheads. And most of you won't even know what an overhead is, but it's a transparent piece of plastic that you put on a light source, and it projects the content that you have written on this piece of plastic. And we had a good conversation with Mr. Dodge, and at one point showed him an overhead that had been produced by someone we know very well, Archie Blyer. Archie's interest was in trying to get a good metric for potential years of life saved from the treatment of cancer. Archie generated this extraordinary figure that at the top had the highest number of potential years of life saved for cancers in children altogether. Right next to it, second most effective intervention was in women with breast cancer. Right at the bottom of this figure is prostate cancer. Think about that. Potential years of life saved. Prostate cancer happens in old people who don't have a long life expectancy. Many of them don't die of prostate cancer. So Mr. Dodge, who had actually entertained us for a little longer than the 45 minutes, eventually said, "I'm sorry, I will have to move on to my next meeting." Thanked him for his attention. He said, "Before you go, I want that overhead." Confused us a little because we hadn't spent a lot of time addressing it. So we said to him, "Why do you pick that one?" He said, "Because my next meeting is with the prostate guys." Anecdote has some resonance, as you might imagine, as time has gone on. Now let me jump to a totally different dimension. I gave up clinical practice 6 years ago because I was spending more and more of my time in pediatric oncology in low and middle income countries, where more than 90% of children with cancer live. We are privileged in this society, among others, in high income countries, to have good resources to treat overall a pretty small number of the kids with cancer. So how best to deal with children in these resource poor settings? That's been the continuing challenge. And I would say to you, all of you, if you get the opportunity, sometimes it'll come up and bite you, but often you can make the opportunity. Take the chance to go and work in a low and middle income country and help in the care of children with cancer. I can assure you, you will learn a huge amount that is not only relevant to the care of children in those settings, but you can bring that experience back and you'd be surprised how often it's relevant in your own setting. You can spend a lot more time talking about low and middle income countries and children with cancer in that setting. And I'll just leave you with one other little piece of information. Sumit in particular was very involved in Lancet Oncology Commission, sustainable care for children with cancer. a global perspective. And one of the people who was important in that exercise was an individual who was a modeler. This individual figured out that while we knew that many of these children with cancer were having difficulty accessing care, he had projected that almost half children with cancer in low and middle income countries are never diagnosed. Never diagnosed. They never get the chance for cure. So my challenge to you is go and make a difference.
I would like eventually to come back to Ronnie's thing about working in low-income countries and give you an opportunity to do it actually immediately if you're interested. But I think I'd like to go back first to this issue of how things have changed over years that we started with. And I remember very well, I think even before I went to medical school, reading books like The History of Surgery, The History of Medicine, and reading about, Lister and what happened. And I just imagine the excitement of you have all these people with dying from infection and sepsis, and then Lister comes along, and all of a sudden things change and change very dramatically. And then, of course, the issue with penicillin and insulin and all of these things, and thinking how exciting the anesthesia, for example. I mean, history of surgery, the surgery before and after people actually produced general anesthesia, and how they had to tie people down, to actually do surgery on them or give them lots of alcohol and tie them down and then sit on them, to actually do the surgery, and how exciting all of this must have been. And thinking, you know what, I'm not going to have that experience in my life because I'm not going to change that dramatically. Well, that's not true, is it really? Because what changed dramatically, first of all, when I started in Hemonc, ALL was already at about 50 to 60% mark. So obviously that's been a dramatic but slow improvement over the years to our modern 90 to 95% in our high income countries. But other things have changed. So I remember very well when I was at SickKids and on staff, you got in a Burkitt's lymphoma or leukemia. This was the B bad lymphoma. Because everybody did badly. I mean, the survival was somewhere around 15 to 20% for Burkitt's in those days, until somebody really brilliant, I think this came out of St. Jude's initially, looked at the cytokinetics really of the Burkitt cells and said, this is not the way to treat them. You know what I mean? We have to divide up therapy. We have to levels in the blood and the CSF, and all of a sudden things started shooting up to 60% to 70% to 90%, which or even 94% now with the addition of rituximab. So this was something in my lifetime, not in the old days in history books, but actually that we could see and experience. And I think very similarly, the same thing happened with T-cell ALL, which was the terrible. That was what T cells stood for, and that's completely changed. As we learned what we needed to do for these conditions. So I think we've had the real luck to experience actually some of these major changes. I don't claim to have been the person who started them, absolutely, but to have implemented them and to see them and to actually produce these results from what we really experienced in the early years is an amazing thing. And there obviously is still a lot in these areas. I'm not sure that we can, certainly I'm not talking tumor, Daniel, at all. But in leukemia and lymphoma, I'm not sure that intensifying chemo or even changing maybe the way we give chemotherapy is going to make a lot of difference. But certainly there are things that are, when you look at what's happening in the future. So we know even now that 20 to 25% of the kids we cure are going to have major, and we don't yet quite know how to predict that group, what to do about them. Although I have some ideas on that score, I'll be honest with you. But you know, there are things that need to be done in this sort of sphere, that where, yes, we can improve survival, but to go to what Mark and Ronnie have been talking about into effects and malignancies and late things, there's certainly a lot of work that can be done and that you can see things changing in your own lifetime as well.
Maybe I'll ask one last question. This doesn't have to be each person, but one person can take it, or more than one person, and then we'll take it to the audience. Just building on what you said, Sheila, about cure rates and such, I think everyone in this room who works in any capacity in pediatric oncology has had the experience of people asking you, you know, that essay, the cocktail question, right? The cocktail party question. How do you do what you do? And maybe I can ask if anyone wants to talk about, in an era where Burkitt's was 10%, or in an era where ALL was just ALL and the vast majority didn't do well, what it was like and how you actually cope with that at that stage.
It's a fair question, and I'll answer it my way. I think the reason I went into medicine was to help people. It really was. It was to, and I use the term traffic in mercy. And I think there are many ways that you can traffic in mercy. Some of it has to do with cure. Some of it has to do with how you cope with catastrophic outcomes. Some of it has to do with supporting parents whose kids may never be the same, or whose kids won't survive. And that whole spectrum of trafficking in mercy is hugely rewarding. Tough, demanding, but hugely rewarding. I, at this stage of my career, can say I really touched a lot of people. And one brief anecdote. A patient of mine we treated for osteosarcoma when she was 10 just wrote me a letter to say, "Dear Dr. Greenberg," she's 35, "I have just had my first child, a little boy, and I named him Mark." That's the reward.
Oh, I think the easiest thing for me to do is to pick up on Mark's theme. And when I say pick up, remember how I started out, because a lot of this is learning on the job. No two families are quite the same. No two children are quite the same. So the challenges that the children and their families face are remarkably diverse, which means that those of us who deal with them have to be aware of that diversity and have to essentially tailor for each child and family how we manage. Some people would say that's not a word you should ever use with respect to the care offered to a child and family, but how we care for that child and family. That's a continuing learning exercise. I don't think we'll ever be totally comfortable in saying we have the answers. This is how you should approach mother and father of a newly diagnosed child with leukemia, for example. You have to take what hints you get from the parents and use that to guide how you then help them best. But sometimes it's useful to reflect on where you might have done better. And I'll share an anecdote with you of a 15-year-old girl had a bone sarcoma, and she was extremely bright. This little girl, got so little at 15, had already won competitions in dancing and in playing the violin. She was obviously going to be somewhat restricted in terms of her ability to dance after substantive surgery and considerable physiotherapy following surgery and all the chemotherapy that went with it and so on. But I remember rounding with a group of students one day, and we popped in to see this girl. And she said, "I've started to write a book. This will be about your experience as a patient." "Yes, and I've come to the chapter on doctors." "Ah." He said, "I'm going to classify the doctors according to their noses." That's an interesting notion. "Why would you do that?" She said, "Because you come in, I'm lying flat, you're standing at the side of my bed, and all I can see is right up your nose." You can imagine that resulted in a certain change of behavior on my part. So it's important to listen.
I mean, it's absolutely true, Ronnie. I always start off a disclosure by asking the parents where they're coming from, what they understand before any disclosure. And then you try and cover whatever and try not to be critical if they haven't been vaccinated, although, inside that's sort of tough. It really is. But this whole issue of first of all, I was already lucky in the sense when I came in that there were survivals and you could cure people, and therefore it was absolutely worth doing. I mean, I would like to just give a shout out to Dr. Marilyn Sonley. Can you hear me? Yeah, is that right? So, Marilyn Sonley was the pediatric oncologist, the only pediatric oncologist in the entire province of Ontario when I first started at SickKids. And she dealt with every single cancer patient in Ontario by herself. And generally speaking, before that, at a time where pretty much nobody survived. And she had a lot of lessons that you could learn from that. But what I learned myself over the many years is that you absolutely do get involved with the patients. You do, the people who don't do well, you do feel very sad at the time, although you don't tend to necessarily take it home with you. In the sense, what I'm saying is I'm not the person who has to go home to the empty room and the kids' clothes that they have to pack up, the emptiness in their life. You know what I mean? So it was easier, certainly, obviously, for me than for the family. And what I found over time was that the ones that I never forgot were not the people that did well. It was the people that didn't do well if I felt that I hadn't done the right. If I felt that I had done whatever I could at that particular time. I mean, obviously things changed, so just one example of that is I went to Cambodia as the doctor, and there was an 18-year-old girl there who I had treated when she was 2 years old. And in those days, everybody got cranial radiation, right? And boy, did I learn that's not a good idea in a 2-year-old, really. So things changed. But if I felt that whatever I could do, I did, and if it didn't work, but I did everything that I could have done, I didn't take it, it didn't last for pretty much forever. On the other hand, if I felt that I had done something that I maybe with the best of intentions shouldn't have done, you never forget it. And I'll give you an example of that. I had a little patient with rhabdomyosarcoma in the days when I treated that alveolar rhabdomyosarcoma, and it went right across the hip joint. She was, I think, 2 or 3 years old. So I didn't think radiation would be a good idea for this kid, right? And it was a time where COG had said that for alveolar rhabdo stage 4, they were curing with chemotherapy alone, right? So I thought, okay, I'm going to give her chemotherapy alone for this rhabdomyosarcoma. And she did respond at first, but of course she recurred, and eventually she got radiated anyway and still died. And that's something, yeah, I've never forgotten that, right? Because I just felt it, with all good intentions in the world, it was the wrong decision at that particular time. So that's just something that I've learned over time, that I could handle it if I felt I did what I had to do, but I couldn't handle it if I actually looked back and said I should have done something different.
Thank you for that. Opportunity for questions either from the floor. If you are going to ask a question, I think you can turn on the mics. And if there's any folks online, I think we can see the chat from where we're sitting. So you could also type a question into the chat and we can read that out. So I don't know if there's anyone up here who wants to start. Daniel.
Can I ask about paternalism in medicine? Because my impression is that medicine started very paternalistic and the doctor knows best. And then things have shifted substantially towards the doctors not telling the families what to do and family-centered care. And I wonder, I mean, my sense is that maybe the pendulum has swung too far the other way, and that to an extent, families are sometimes directing decisions or coming with Google research or other ideas about how to treat, and that in a way, the role of the doctor as the expert who's actually got the background knowledge has kind of shifted over time. And I wondered if you could comment on that and what your experiences were, and whether you'd noticed a difference over time.
So I'll start by sharing a personal anecdote. I was the father of a child with a brain tumor. I was an oncologist at the time. And what I really needed, and what my family really needed, was the doctor to guide me. We are, as a parent of a child with cancer, your ability to make decisions that are objective and in the best interests is lousy. And I learned that very quickly. I'll follow with another anecdote. On Christmas Day one year, was when I was on call, a child was referred who had a mass at the lower end of her vertebral column. That had been biopsied on the outside. It was called Ewing sarcoma. And when I walked in to meet the family and the child, the father stood up and said, "I am a professional engineer and I have reviewed the literature." And he handed me a sheaf of papers in which he had highlighted the treatment for Ewing sarcoma and assured me this was how he wanted his child treated. But I said I thought we should probably wait and review the pathology, which turned out to be a B-cell lymphoma. And when I went in to explain this to him, he looked at me and said, "I was a horse's ass, wasn't I?" I said, "Yep, but it's okay."
I think that description is by and large true. I think back to days in particular when I was an internist, and the senior consultant would come around and make decisions from the end of the bed, convey them to the patient, and move on to the next. No questions and answers. I think you're also right that there's a danger that the pendulum has swung too far the other way. And Mark has given a good example of that. I think there are many reasons why that has happened. One of them is that the expectations that families have now are different from previously. They come with an expectation that having been given a diagnosis of malignant disease in their child, the child will be cured, and anything short of that is a failure, and the failure doesn't reside with the family or the child. So I think there's a big difference in expectations. There's also, and Mark has alluded to this, a huge amount of misinformation that is readily available. And sadly becomes a point of contention often between the conventional therapist and the family. We see this almost structured in some circumstances. And I hope nobody is offended by this, but the common example is children of Jehovah's Witnesses. That poses a very particular challenge. Sadly, it often ends up in a confrontation because there appears to be no middle ground. And if the child has a high prospect for cure, all too often the outcome is, I'll see you in court. And the track record on that is that our legal system will usually side with the physicians. We've had examples where that wasn't true. Jehovah's Witness example didn't pertain in that instance, but it related to children of indigenous families. That can be particularly challenging. Sometimes some of the challenges are almost farcical. I can remember a child, I think with ALL, but it almost didn't matter what the disease was. And the family were determined that they would have an exercise that was approved by their elders take place in the child's room. Problem was it was a fire hazard. How to get that resolved required the input of a lot of people who are not conventionally involved in healthcare. So there are many challenges but I think you're right that it started out being very paternalistic, and the pendulum probably has swung in some particular circumstances too far the other way.
Maybe just so we can get in a couple more questions, open it up again to the audience, and maybe just one person, whoever feels like they want to take it, and then we can do some 3 or 4 questions before we wrap up. I see Lee reaching for.
Hi, this has been fascinating. Thank you so much.
Lee, can you talk directly into the mic?
Oh, sorry. I'm going to have to sit in Lillian's lap. There you go. You can have my chair. No, there. I wonder what your comments are and reflections are about the change with respect to the allied health role on the team throughout your career. And Mark is smiling because he was maybe expecting that question.
Who wants to take that one? Sheila?
Well, I think Lee, you know very well that it has changed. It's changed a lot. I mean, there was a time, certainly when the others, but when we first started, where it was not considered that important, you know what I mean? We were the top of the pyramid, and that was what counted. And that certainly changed over time. You know, I think what it is today, which is, I think, an absolutely integral part of the team, and that it is definitely a team effort. You know what I mean? Social work, nutrition, pharmacy. I mean, you know, just to give you a little boost, I think one of the best innovations we've ever had are the clinical pharmacists on the oncology unit and in clinic. So unbelievably helpful, and I'm sure, although I haven't looked at it personally, has reduced the risk and the incidence of errors and things like that. I really do. I think it's an amazing thing happened. And so I really do think, and you know, from the point of view of nursing, I mean, when I first started, we used to mix ourselves, we used to give it, we did all the IVs, all that sort of stuff. And of course now that's completely different. You know, I think the role for all of us has changed completely, and is actually we're in a much better place right now with this team effort rather than, you know, the person at the top and then the rest were just hangers on, so to speak. So no, I think it's been a big deal. Yeah.
I agree with that wholeheartedly, Sheila. And we've actually taken it a step further in Hamilton, because every child and family has a formal interaction at the time of diagnosis with a clinical pharmacist, with a nutritionist, and usually, almost always, with a nurse practitioner. And there may be reason to have other healthcare professionals involved, but at least at that very important point in their trajectory, right at the beginning, to have that amount of expertise available has been a huge advantage. The other advantage is that as physicians, we've come to learn a lot. And so it's become a much more dynamic process, that even though, and you know, the senior clinical pharmacist in our place, Lee, who goes in and talks to the family in great detail, and then at our sit-down rounds, explains what he has said to the family. That's a big learning exercise for the rest of us. So I think that's this broadening of the, what do we call it, the circle of care, has had benefits for everyone involved.
Please. Do you mind turning on the mic just so the people online can hear you as well? Thank you.
Hi, sorry. Over your career, the city of Toronto has evolved. There's so many new immigrant populations that found a home in Toronto. Medicine has changed, new treatment plans, new biology has also been found. So how do you adapt to this change throughout your career? How do you keep up with all the knowledge, or did you ever find it very difficult throughout your time?
That's a really tough question. For those of us who are a little longer in the teeth, I think it has become more and more difficult. And I think one of the solutions that's happened is more and more coning. So on my right sits the head of leukemia and lymphoma, on my left, the head of solid tumors. And more and more, I think the focus that you put on your particular piece of the pie, and we can do it perhaps more efficiently at a place like SickKids, where our staff is much bigger. But I don't think, when I started to talk this afternoon, I said, when I started, we all did everything. And progressively, more and more was cleaved off, because you needed to have some expertise there. I mean, I could no more look at a post-op cardiac patient bleeding, then I would expect them to be able to treat a brain tumor. So I do think that's the way to go. There is more and more knowledge, and will continue to be more and more knowledge. And so I think there's some mix of depth and cross connection. I think of my friend and colleague David Malkin, whose area of expertise cuts across tumors, and Eric Buffet, who was just on the screen here, whose expertise goes this way rather than that way. And I think, again, that's why pediatric oncology is a team sport. We got to do that.
Because I think that what we have done at SickKids, as you know well, is we have siloed these things. But I do that we have lost a lot by that. I mean, personally, I think what it does allow, of course, is for you to be much more knowledgeable about silo, but much less knowledgeable about stuff that we used to know. We did everything. And honestly, if you had to ask me now to treat a stage 4 neuroma or rhabdo or anything else, I'm not the person going to do that. So I think, no, maybe not stage 4 neuroma either, but ask you. Still not sure I could do it. But you know, I think we gained a lot and we lost a lot by doing that. But you know, it does allow you to concentrate on one area.
Yeah, the other thing that's changed is the ready availability of up-to-date information. We were talking before we came in, Sheila, about the fact that you used to go regularly to a meeting on lymphomas in Lugano. You can find a meeting on just about anything, anywhere. And so I don't think there's any shortage of information. How you deal with the acquisition of that information and then translate it into your own practice is a bigger challenge. I told you about my original mentor, and one of his words of wisdom to me all those years ago was, Ronnie, you have to understand that the more you know translates into the less you know. In other words, you become more and more knowledgeable about ever less in the way of subjects. Sheila's point about the siloing. And that was, good Lord, more than 50 years ago. He had that perception that that was the risk that we were going to fall into. And I think he's been right to some degree.
So I just want to add one comment. I think there are certain components of the knowledge spectrum that are common across the board. The process of decision making, weighing risk and benefit, adjusting the particulars of therapy to the particulars of the child. And that's applicable across silos. And for me, that's what Tumor Board was about. We had a intersection of expertise in a particular domain of oncology and a bunch of people around who said, yeah, but should we radiate this 2-year-old? What's the benefit? What's the cost? And I think we need both of those components. There are principles that we could adhere to and should.
I think being cognizant of time, although I think many of us would like this to go on all evening, are there any other pressing questions that anyone wants to ask up there? I think I see Annie
Annie up
at the
there.
back.
Hi, this is a great session. I'm reminiscing. I just want to ask, like we train people longer and longer. From your lens, given all the changes, like if you had to fashion a model where people can train and still get on with their life, like how would you fashion it? Because we seem to be extending training for a very long time.
Annie just became all the trainees' favorite staff. Sorry, so the question was, training has by design or by happenstance become longer and longer as the expectations to get more and more experience, more and more accomplishments. I guess, Annie, I think if I'm understanding correctly, like in your opinion, what's the right balance to be a pediatric oncologist now in terms of like what training do you actually need? How do you balance those things from your perspective? Easy question.
I think before you have gray hair is the
Or any hair.
I think
I
you
s-
have to be able to make choices, in what you're going to do. So you have to be exposed as a trainee right across both to him and make your choices. And it really is important to do that training, because I was just sitting thinking, actually privileged to be able to following. I think did not that she did all the hematology. And I once asked her actually how she managed that, and it was very much protocol driven. In other words, she would go with the COG protocol, and she did it very, very well, and the patients did. It might not completely ideal, but that is the way some people have to practice. You know what I mean? They have to do just right across the board. And unless you've had that initial inning, first of all, you can't make the choices that you might. That secondly, day before practice people around, either because the patient number doesn't allow, finances don't, and so you have to. It is long, yes, but I think it's needed. I really do.
I just wonder though the balance between, because the amount of information sorry, I just wondered about the balance, because I was putting up a slide one day and I thought, okay, now it's coming up, will take us 7 years to be a pediatric hematologist oncologist, 6 years to be a neurosurgeon still. And I always wonder about the amount of information we have is exponential and it will continue to grow. So from a sort of really pedagogy sort of point of view, is how do you construct a system where perhaps the critical thinking skills, rather the consumption of fact, and that we seem to feel a need to deliver, even at the very primary school level. Do you know what I mean? Because the amount of information is just increasing and increasing, and I don't think that people want to train for more than 7 years, right? It's a very long training. And we lose people at the other end, right? Because then we don't have people who want to take up more of an academic training or more specific training and research and stuff like that. So just a philosophical question I always struggle with.
I suspect Angela may want to talk to you afterwards about her ideas, but
I
so
think it
maybe
might be worth pointing out it's a particular challenge for women. At least in this province, and I suspect pretty much across the country, the government made a terrible decision years ago in its projections about the number of physicians it was going to need. and therefore the number of positions in medical schools that were required. Huge underestimate. What they also didn't factor in was the proportionality of those who entered medical schools. What is it now? 60% women? It's of that order, right? And the time that these new graduates spend over their lives in the practice of medicine is quite different for men and women for the most obvious biological reasons. I haven't seen any example of how that's been integrated into the projections of how many physicians we need. And then you throw into the mix the fact that people are giving up, wanting to have careers in general practice, for example. So that the planning of the careers of physicians at large is a challenge that I think has been poorly addressed up to now. It's a little different from your issue about how long you should train, but it's relevant to that consideration.
So maybe just again, not to keep our guests who have come all this way too long afterwards, maybe we'll finish up with one question just to each, and I'll ask you to keep it just to a quick minute. If you could go back and sort of talk to yourself at the time when you first entered the oncology, pediatric oncology world, and tell that version of yourself one thing, what would it be? So if you, yeah, that was overly complex, wasn't it? If you could go back in time to when you actually started as a pediatric oncologist, whether it was a fellow or a staff in Ontario, and tell that person one thing that you wish you had known then, what would that thing be?
I think I would tell myself it is a hugely rewarding career. Stick at it.
Which is amazing. Actually, I would wish that for everybody. Feel like that.
See, I think that, and then, you know, a little bit of dating advice right at the very end, I think that's a good place to leave it. Paul, anything else?
Just, I want to thank the three of you. I mean, as someone, and there's others in this audience who benefited personally from the mentorship of all three of you early in my career, and the lessons I learned from all of you resonate still today. I just want to thank you for sharing with everyone else. We were immensely privileged to have mentors like you, and I hope those of us that are now sort of this up and coming and next generation can continue sort of new folks in the same way. Because honestly, you can't get a better start than what we got from the three of you. So thank you. Thank you for sharing. And if anyone wants autographs, they can come down afterwards. And just have a good evening, everybody.